Hey guys, it's Medicosis Perfectionalis one more time. This is the fourth video in our rheumatology series. In the first video we had an introduction, the second video we had learning the basics, and the third video we understood the interpretation of labs in rheumatology. Today I'll tell you how to take a good history in rheumatology. So let's get started. Some words of wisdom from the father of medicine. Wherever the art of medicine is loved, there is also love of humanity. This is so deep. What does rheumatology mean? Rheuma means flow because they thought that there are some fluids floating in your body, carrying symptoms to different organs. And here are the previous 3 videos. Make sure to save my playlist. It's called Rheumatology. As I've told you before, rheumatology is different from hematology. Hematology, for example, you can perform a bone marrow biopsy, send it to the pathologist, we have the tissue pathology, boom, we have the diagnosis. Rheumatology is different. You can't depend on only one lab test. Just because you have positive ANA doesn't mean you have lupus. It could be normal, it could be lupus, it could be a bazillion other things. The test has to fit with the patient's history and physical exam. And as they say, if it looks like a duck, swims like a duck, quacks like a duck, it's probably a duck. This is called pattern recognition. Rheumatology is like a puzzle. You have to connect the pieces together, but don't be a child. If there's one piece missing, it's not a big deal. Don't be like, oh, there is a missing piece, I'm so angry. No, if you are expecting 10 pieces and you only found 8, that's good enough. You can still diagnose based on that. When you hear hoofbeats, think of horses, not zebras. Common things are common, except when they are rare. There are 2 distinct categories in rheumatology. There is the non-inflammatory, also known as mechanical problems, such as osteoporosis, for example, and the inflammatory. You have rheumatoid arthritis, you have lupus, you have the seronegative, which are HLA-B27 positive. Why seronegative? Because they are rheumatoid factor negative. The physician-patient encounter. First things first, who's the most important person? The answer is the patient. I know that you have many certificates on the wall that say that you supposedly know something. However, only your crazy colleagues care. The patient couldn't care less about which school did you go to or what your score was. In the University of Pittsburgh, there is a very nice paper posted that says, what you see here, what you hear here, what you leave here, let it stay here. Patient confidentiality. What's the most important goal, believe it or not, is to win the patient's confidence. Some of you might argue, the goal is a better medical outcome. Okay, but you will never get a better medical outcome if you can't win the patient's confidence. You should be pleased when you see a patient. You should have passion and perseverance for your career. Don't be that kind of a doctor who says, thank God it's Friday, oh God it's Monday. You should feel privileged to treat patients. Something your professor will never tell you. That's why he's a professor. He's not a caregiver. Arrogant people should never be allowed anywhere near patients. To prove to you that winning a patient's confidence is very important, there was a recent study in the United States that concluded that Americans are more likely to fill the prescription for their dog than they are to fill the prescription for themselves. They go to the doctor, they get a prescription to the pharmacy, but they never go to get the medicine. That's tragic. But when you ask any doctor, they say, oh, we do our best. Patients just don't listen. Shut up. Next, what's the history? The history is the story that the doctor composes to help him diagnose and treat the patient. So what's your reference? I'm old school. I read books because the information that you get on the internet is worth exactly what you paid for. Nothing. There's an amazing, brilliant book called Sapira's The Art and Science of Bedside Diagnosis. Another book called Hutchison's Clinical Methods. They are just amazing. Links in the description. You should read if you want to be a better person. And of course, you should watch my videos. They are worth exactly what you paid for. You should have a blueprint or a methodology or an approach to every patient while taking history. First, we start with the complaint. What's the symptom, the main symptom? This is also known as history of present illness or HPI. Then the past medical history. How about the past surgical history in the past medical? General questions about like the health of the patient, diet, exercise, sleep, travel, etc. Family history. Has anyone in your family been diagnosed with this condition before? How is the health of your parents? Are they alive and kicking? Social history. What do you do for a living? Sexual history. Are you sexually active? Stuff like that. And if you are a female, OBGYN history. But what about men? Okay, shut up. Nobody cares about your prostate gland. So history of present illness, you ask what's going on. Past medical history, previous occurrence. Have you ever had this problem before? Medical conditions such as hypertension, diabetes, maybe you can add high cholesterol. Allergies, do you have food allergies or any environmental allergies? Drug allergies, are you taking any medicine? This is a very important question. Have you been hospitalized before? Have you ever had a major surgery? Not any surgery. Going to the dermatologist to remove your nail because it has pus underneath doesn't count. General questions about sleep, diet, exercise, and travel. Family history. Social history. What the flip do you do for a living? And any substance use. Cigarettes, alcohol, and the heavy stuff. Sexual history. Are you sexually active? Yes or no? With whom is a very important question. With my wife for 50 years is way different from with 72 partners in the last week, okay? From a medical standpoint. OBGYN, have you been pregnant before? And the result of the pregnancy is very important. All that I've mentioned until now is general. Let's get more specific to the rheumatology patient. They complain of joint problems, such as what? The famous triad. Pain, stiffness, loss of function. Skin, you can have rash, lesion, swelling, sweating. Eye problems, bowel problems, malignancy. Remember multiple myeloma? They have bone fractures, they get bone pain. In fact, bone pain is the most common symptom in multiple myeloma, especially on the vertebra. Let's leave the rheumatology patient alone and let's talk generally again. Any patient that complains of pain, any kind of pain, you ask these questions. I like this methodology. Many people use other stuff and other mnemonics like Socrates. I don't like that. I like Socrates as a philosopher, but not as a mnemonic. I use this. Site. This is the most important question. If they say, doctor, I have pain, don't say, when did it start? Does it radiate to where is the freaking pain? Not just where's the pain. Show me where's the pain. And here's a pearl for you. Let's say that there is a patient coming in and they suspect they have a heart attack. Show me where's the pain. If they point with one finger, this is not cardiac chest pain. This is not a heart attack. Heart attack, they point with the whole hand because it's poorly localized. Medicosis is spitting wisdom all over the place. Onset. Is it recent? Is it chronic? Then, course. Is it worsening? Is it improving? Is it fluctuating? Time of the day, is it worse in the morning, worse at night, stuff like that. Duration, when you have the pain episode, how long does it last? If they say like, I have chest pain for 3 seconds, this is not a heart attack. If they say I have chest pain for 4 to 5 hours, this is not a heart attack. Because heart attack is never seconds and is never hours. It's always minutes. I'm spitting wisdom. Then distribution or radiation. Does the pain follows a dermatome? Does it radiate like chest pain, like cardiac pain radiates to the left arm? Character. Is it dull? Is it sharp? Is it waxing and waning? Because there are two different types of pain. There is the nociceptive pain and there is the neuropathic pain. We'll talk about them later. Severity. On a scale of 1 to 10, how helpful was our sales representative today? Oh, I'm sorry, this is customer service. Back to patients. On a scale of 1 to 10, 1 being the least pain and 10 being the worst pain ever, how bad is your pain? Then aggravated by what makes the pain worse, relieved by what makes the pain better, associated with. So in order to memorize them, it's very easy. First you start with the site. Then onset, course, duration. Duration ends with a D, you start with a D. Distribution. Character and severity together, then the prepositions together. Aggravated by, relieved by, associated with. Let's go back to the rheumatology patient. I have joint pain. We'll ask him all of these questions. So let's start. But first, please keep this in mind. Rheumatological diseases are either non-inflammatory or inflammatory. Huge difference. I have a joint pain. First, site. Show me the pain. Let's say the big toe. Think gout. Onset. Is it recent or chronic? Oh, doctor, it started yesterday night after eating meat and drinking wine. This is gout. If it started today morning when I was carrying a grocery bag, suddenly I felt pain. It was severe. This is a pathological fracture. If it started today when my hat didn't fit my head, this is Paget's disease of the bone. If it started 2 days ago, acute, severe, continuous, throbbing, this is a joint infection. On the other hand, if it started 3 weeks ago, it's constant, severe, it prevents me from sleeping. And by the way, I've lost weight, this is malignancy. Again, it depends. How about the course? Is it worsening, improving, fluctuating, and the time of the day? If it's continuous, severe, and throbbing, infection, such as septic arthritis. If it's intermittent, worse at the end of the day, this is osteoarthritis, because osteoarthritis is a mechanical problem. The more you move, the more your bones hit each other, the worse the pain. If the pain is worse in the morning, improves as the day goes on, this is rheumatoid arthritis or any other inflammatory arthritis. Why? It's inflammatory. As you move, you wash out the inflammatory debris and the pain improves. So, rheumatoid arthritis is worse in the morning, osteoarthritis is worse in the evening. Rheumatoid arthritis, morning is worse. Osteoarthritis, the mechanical one, evening is worse. Makes perfect sense. Next, let's talk about duration. Morning stiffness for less than an hour is osteoarthritis. Think about it. It's a mechanical problem. Think about your car. Sometimes when you are driving an old beater like me, when I put new tires on my car, I double its value. Anyways, when you start the car who has a mechanical problem, at first it's struggling. But once you move and start moving a little bit, after like 10 to 20 minutes, it improves. At the end of the day, the parts are worn out and you end up stranded at the side of the road in the middle of Egypt. This is the same as osteoarthritis. Morning stiffness for less than 1 hour. As the patient tries to move, kind of okay. At the evening, due to friction and movement, it's the worst thing ever. On the other hand, if you have morning stiffness for more than 1 hour, this is probably inflammatory arthritis. Think rheumatoid arthritis or ankylosing spondylitis. Some authors say not more than 1 hour, but more than 30 minutes. I couldn't care less. So, morning stiffness less than 1 hour is osteoarthritis. Morning stiffness more than 1 hour is rheumatoid arthritis. Let's talk about distribution and radiation. Okay, if you have neck pain, the neck pain radiates to the occiput, the back of your skull, and to the vertex. Fine. They may radiate to the shoulder and down the arm. If there is nerve impingement, you will get paresthesia, which means numbing, tingling, etc. Let's talk about shoulder pain. Shoulder pain radiates to the elbow and beyond, like Toy Story, to the infinity and beyond. Thoracic spine pain will radiate around the chest and it can mimic cardiac pain. So whenever the patients come in with chest pain and he thinks he has a heart attack, one of the differentials should be thoracic spine nerve root pain. How about the lumbar spine? The lumbar spine radiates to the buttocks, to the thigh, to the knee, and beyond. This is called sciatica. Hip joint pain will radiate to the knee and beyond. Knee pain will radiate above the knee and below the knee. On the same side, of course. If it's the left knee, above and below the left knee. Nothing with the right knee. Don't be stupid. Character, I've told you there are two different types and we'll talk about them later. Aggravated by, what makes the pain worse? It's worse with movement. This is probably a non-inflammatory such as osteoarthritis. On the other hand, if the pain is not affected by movement, it's probably neuropathic pain. Relieved by, if the pain is relieved by movement, it's probably rheumatoid arthritis. Associated with, if it's associated with paresthesia, which means tingling and numbness, think nerve impingement problems. If there is a clicking sensation, this is osteoarthritis. What the flip is clicking? Clicking is not the same as crepitus. Clicking is when your knee is locked or stuck in a position and you cannot fully extend the knee. Why does the knee click? Probably there is a mechanical body interfering with the joint movement, mechanical body such as cartilaginous body or a meniscus. Sometimes this locking is associated with pain and followed by swelling. Next, you should ask the patient, is the pain associated with any other pain in any other joint? Because if it's only one joint, monoarticular, think infection. Here's another pearl for you. If the patient complains of knee problem or knee pain and the knee didn't swell, the knee is fine. The problem is not in the knee. Think about like the tibial tuberosity or the tendon of the quadriceps muscle or any other stuff, but it's not the knee. When there is a problem in the knee, it swells. What if the knee is swollen and inflamed, it's red, swollen, and it's warm? What's the next step? The next step is to tap it. Stick a needle inside the knee, called arthrocentesis, and send it to the lab. And here's a mnemonic for you. If the knee loves you and is blushing, which means red and swollen, she's aspiring to you. You should feel it, aspire it, and send the fluid to the lab for culture and crystals. Just a romantic mnemonic. Here is the famous triad of rheumatology: pain, stiffness, and loss of function. If the pain predominates, think osteoarthritis. If stiffness predominates, think inflammatory arthritis. And if the knee is swollen and blushing and aspiring to you, aspire it. So if you see redness, hotness, swelling, pain, think inflammatory arthritis. Past medical history, you ask all of these questions. Be aware of medications because many medications cause SLE-like, lupus-like syndrome, such as hydralazine, procainamide, isoniazid. General health questions. How's your sleep? Oh, doctor, I can't sleep. I'm so tired. I'm very depressed, and the pain is like mad in all of my joints. This is chronic pain syndrome, also known as fibromyalgia, more common in women. Diet. I eat lots of meat and drink lots of French wine. Gout. I'm a strict vegan and I have pain. This is probably neuropathic pain due to vitamin B12 deficiency. Does that mean that all vegans will get vitamin B12 deficiency? Of course not. Many of them are educated. They get supplements of vitamin B12, and some of them are rich. They get $13 smoothie with vitamin B12 supplement in it, so they should be fine. And don't forget, your liver stores vitamin B12 for a long time. Ask about travel. Oh, I went hiking in Maine, which is in the northeastern United States, and I get this joint problems and I think I had a rash. This is Lyme's disease. And also, in rheumatology, never forget review of systems. Review all of the systems from head to toe. The patient had hair loss, oral ulcers, malar rash, fatigue, bleeding, infection, joint pain, blood in the urine. This is lupus baby. If a patient had ear, nose, throat problems, sinusitis, deafness, and facial pain, this is granulomatosis with polyangiitis. If the patient had ear, nose, throat problems, sinusitis, deafness, and facial pain, plus allergic rhinitis and asthma, this is Churg-Strauss disease. I've been pregnant 5 times, but unfortunately there is spontaneous miscarriage every time. This is lupus. All of my family had back problems, back pain, and scoliosis. This is ankylosing spondylitis, more common in men. All of my family have very thick skin, literally not metaphorically, to the point that they can't move their extremities. This is scleroderma. What the flip do you do for a living? Oh, I'm a tennis player. Think about tennis elbow. I'm a marathon runner. I'm crazy about running. Think stress fracture. I'm a child taker. I'm a mother. I have a newborn. I take care of him, but my wrist and hands hurt like mad. Think Duker vein tenosynovitis. I'm a soccer player, but yesterday just heard a loud painful click in my ankle and the pain was unbearable. This is Achilles tendonitis. I'm a babysitter. I went with the child to the grocery store or the supermarket, and the child was angry and crying and throwing a temper tantrum on the floor. I pulled him by the hand and he had severe pain since. This is nursemaid elbow, also known as radial head subluxation. Also, it could be shoulder dislocation. I'm a typewriter. I'm a clerk for the local county court. Or I'm a paralegal or secretary for a famous law firm. Or I'm a news reporter typing 62 articles a day. Or I'm a fitness and lifestyle blogger, God help us. Think carpal tunnel syndrome. So bloggers get carpal tunnel syndrome while Instagram influencers have narcissistic personality disorder. We should update the books. All of these are soft tissue symptoms. Dull aching pain, swelling, tenderness. Think either injury or joint overuse. Sexual history. Are you sexually active? Yes. With whom? With my husband for 39 years. This is not relevant to our case. With 16 guys last night, and today I have knee problems. This is gonococcal arthritis. Here is another pearl for you. If you want to find the gonococci bacterium, don't look in the knee. You'll find the bacteria in the genital area, so do a pelvic swab and send it to the lab. OBGYN history. I've been pregnant 5 times, but spontaneous miscarriage every time. I have history of venous thrombosis and livido reticularis. This is antiphospholipid antibody syndrome, also known as lupus anticoagulant, which is a stupid name because in fact it's lupus procoagulant. And we'll talk about platelets and bleeding disorders in next videos. But please help me reach 35,000 subscribers on YouTube. Please, guys. This is education as it should be. To think like a doctor, not as a broke professor with some interesting theories. Thanks a ton for watching and for hanging out with me. Consider supporting this channel on Patreon. You will get all of my notes if you go to Patreon. Also subscribe to this channel, smash like, and follow us on Facebook. I have lots of cases there. Thanks for watching. Until next time, be safe, stay happy, and study hard.